without further ado, I want to introduce Angela Russo, who is from Northwell Health. And I want to just tell you a little bit about Angela. She is a doctor of physical therapy and has been working at Glen Cove Hospital for the past 5.5 years. She currently works on the brain injury unit of Glen Cove Hospital, but has experience working on rehab and acute care floors and outpatient physical therapy. She graduated from NYIT, which we all know very well, with a doctorate in physical therapy in 2015. In the past 2 years, she's been the primary physical therapist working with the patients in Glen Cove's inpatient Parkinson's program, which I think Angela will also tell us a little bit about that program as well. So it is my greatest pleasure to introduce Angela Russo.
Hi, everybody. Thank you for having me today. I'm just going to share my screen here so I could pull up the PowerPoint for you all. And here we go. So my topic today that I'm going to be presenting on is physical therapy in the treatment of Parkinson's disease. And just to give you just some statistics, nearly 1 million people will be living with Parkinson's disease in the United States by 2020. This is more than the combined number of people diagnosed with multiple sclerosis, muscular dystrophy, and Lou Gehrig's disease. Approximately 60,000 Americans are diagnosed with Parkinson's disease each year. More than 10 million people worldwide are living with Parkinson's. And the incidence of Parkinson's disease increases with age, but an estimated 4% of people with Parkinson's disease are diagnosed before the age of 50. Men are 1.5 times more likely to have Parkinson's disease than women. So our agenda for today, I'm going to be discussing the common motor symptoms in Parkinson's, the role of physical therapy, complications, the benefits of exercise. I'll have an opportunity for everybody to ask questions towards the end. And then the very last slide I'll have is a resource list of different websites that are very useful. So, an overview on Parkinson's disease. Parkinson's disease is a movement disorder involving cell loss in the region of the brain called the substantia nigra. The substantia nigra is actually Latin. It means black substance. And the nerve cells, also referred to as neurons in this region, they appear dark under a microscope. The substantia nigra of the brain is responsible for producing dopamine and relaying messages related to movement. Dopamine is a neurotransmitter, which is a chemical messenger that allows neurons to communicate with each other. Dopamine is critical in the central nervous system. It relays the message in the brain to produce smooth and purposeful movements. It's also involved with pleasure, attention, mood, and motivation. This loss of dopamine is actually the reason that many treatments for Parkinson's disease are intended to increase dopamine levels in the brain. Medication Sinemet, which I'm sure you all are familiar with, is intended to increase dopamine levels in the brain. On this slide, I have a comparison. This is a substantia nigra in a normal healthy person on the left-hand side. And remember, substantia nigra is Latin for black substance. We see these dark lines. They're rich and dark in color. And this indicates the neurons that produce dopamine. And if you compare it to the picture on the right-hand side, this is the substantia nigra in a person affected by Parkinson's. And you could see how these dark lines are a bit more diminished in color, not as many neurons present that produce the dopamine. So we're going to review some common motor symptoms in Parkinson's disease. We have rigidity, which is muscle stiffness detected by a doctor on examination. Bradykinesia, which is slowness. It's a decrease in spontaneous and voluntary movement. May include slower walking, less arm swinging while walking, or decreased blinking and facial expression. Tremors could be a resting tremor. It's a rhythmic involuntary shaking that occurs in a finger, hand, or limb when it's relaxed, and it disappears during voluntary movement. walking problems, or difficulty with balance and coordination. This can happen anytime throughout the course of Parkinson's, but it's more likely as the disease advances. We have postural instability, and this is referred to as an imbalance and loss of reflexes, which would typically correct the orientation of the body when it's taken out of normal upright position. People with Parkinson's often compensate by lowering their center of gravity, which results in that stooped forward posture. Dystonias, it's a movement disorder in which there are involuntary and repetitive muscle movements. This causes a part of the body to twist or assume a particular posture. Various body parts can be affected by dystonia in Parkinson's, including the eyes, neck, trunk, and limbs. On the right-hand side of this slide, we have motor symptoms that primarily affect gait. We have retropulsion, which is a loss of balance in a backwards or posterior direction. In my experience, I notice a lot of my patients with Parkinson's, as they attempt to stand up from a chair, they'll fall backwards into their chair, and this is retropulsion. Freezing of gait, also very common. These episodes are sudden, short, transient blocks of movement that occur primarily when initiating gait, turning, navigating through narrow spaces, or approaching obstacles. Freezing can last just a few seconds or up to several minutes. A festinating gait pattern, which is characterized by a quickening and shortening of normal strides. It's almost as though you're falling forward and increasing the number of steps you take. We also have shuffling gait, which appears as if a person is dragging their feet as they're walking. Reduced arm swing, which appears as though somebody has their arms glued to their sides, not really moving the arms much at all. Decreased step length, every step they take is very short. It could be only a couple inches. And the stooped forward posture. So in this slide, I have a video of a gentleman demonstrating a typical Parkinsonian gait pattern. Well, I'll play that for you now.
This gait is the gait that is hypokinetic gait. The prototype is Parkinson's, or Parkinsonian type of gait, in which the patient will have a posture which will be stooped over, leaning forward, and then will have difficulty as far as initiating gait. When the gait is initiated, there are small steps. Oftentimes there's a tremor associated with this. And as the gait progresses, there may be a picking up of speed, or what's called a fenestrated gait. And then in turning, instead of having the normal turning, the patient will turn en bloc, which means they'll turn almost as a statue moving around. And then again, having difficulty starting in the marche petit pas.
So that video was just a good example of some of the gait deviations that I discussed in the prior slide. You saw the difficulty with turns, the festinating gait pattern, and the shuffling steps, which are very common. So what is the role of physical therapy? Physical therapists are defined as movement experts who improve quality of life through prescribed exercise, hands-on care, and patient education. Physical therapists examine each person and develop a treatment plan to improve their ability to move, reduce or manage pain, restore function, and prevent disability. Physical therapists can have a profound effect on people's lives. They help people achieve fitness goals, regain or maintain their independence, and lead active lives. We focus on a lot of different domains in order for our patients to achieve better overall quality of life. Transfers, the ability to perform a sit-to-stand transfer. Lateral transfers going to and from the toilet, to and from the bed, or even in and out of a car. Very important with everyday life. Balance is very important. Being able to balance in sitting unsupported, maybe even at the edge of the bed. balancing and standing. And we refer to different types of balance, static and dynamic balance activities. And static balance activities refer to just being able to stand in place. And this doesn't involve much movement, just being able to stand in place. Whereas dynamic balance is the ability to balance while in motion or switching between positions. We, of course, focus a lot on gait training. We look, especially in the Parkinson's population, to improve foot clearance, cadence, the number of steps per minute, arm swing, increasing the arm swing so they don't appear glued to the sides, turn negotiation, and we address freezing of gait. There are a lot of different strategies to address freezing of gait, festination, bradykinesia, and coordination. We also identify if somebody is a household ambulator versus a community ambulator. Does this person lead more a sedentary lifestyle where they're really just walking from one room to the bathroom or to the kitchen? Then we have to focus on their ability to walk short distances safely and be able to negotiate the obstacles within their own home. If they're more active and are out in the community, we need to address their ambulation outdoors as well. Walking on concrete, sidewalks, uneven surfaces, even grassy areas is important. We address stair training. A lot of people have many stairs they need to negotiate to get into their house. We identify if that patient has handrails to be able to hold on to get themselves inside. How many stairs do they need to get inside? Do they need to negotiate the stairs in a special pattern, taking it step to step, meaning both feet touch the same step, or a reciprocal pattern where they go 1 foot over the other as they're climbing up? That's a bit more advanced. We address posture. As we know, there is that stooped forward posture, which is very common in Parkinson's. We focus on improving upright head position and overall postural stability. Pain management, which can be addressed with massage and modalities such as heat packs or cold packs. You know, I work here in a hospital, so I easily can request the nurse who's in charge of treating that patient for some Tylenol or any sort of pain medication that my patient is requesting. We also perform stretching for the rigid muscles. If people have muscle cramps or even dystonias, we stretch those muscles out. It's very important. And of course, strengthening is key. Being able to strengthen the muscles to improve gait, to improve stair negotiation, and improve overall quality of life. Endurance training, we sometimes get our patients on like a recumbent bicycle, or even over here in our clinic, we have a treadmill, which has a harness support that is connected to the ceiling. And it unweights their body and allows them to be able to walk on the treadmill safely, which is a really good option. Big part of physical therapy, especially in the treatment of Parkinson's disease, is fall prevention. Our program, we primarily get referrals from patients' doctors for them to come and participate in our program because they're having a decline at home, because they're noticing more falls at home. So we see them for a total of 2 weeks as a tune-up to be able to get them stronger and safer and prevent falls from occurring at home. Approximately 38 to 68% of Parkinson's disease patients experience falls due to gait disturbances. So some of those gait impairments we discussed earlier, you know, the freezing of gait, the festination, even the shuffling. If you're not getting proper foot clearance, you could trip very easily and fall forward. We identify what the cause of the falls are in each of these patients and review ways to prevent these falls from occurring. We provide education and training on how to safely transfer from the floor after a fall, which a lot of people don't know how to do. They kind of panic once they're already on the floor. And if they're lucky, they have a loved one present to be able to assist them up off the floor. But in case of an emergency, in case they're alone, they need to be able to transfer onto their hands and knees in what we call the quadruped position, be able to crawl safely to the nearest chair or couch, any area that they could get to be able to pull up to sit. We advise a lot of patients to have a life alert button handy or even a cell phone on them at all times to be able to call for help. We also train on avoiding risky behaviors. And what I mean by risky behaviors is I've had a lot of patients that believe they're able to do a lot more than they can do safely. So for example, if there is something that they need that's on the highest shelf in the kitchen cabinet, they feel like they will be able to climb up onto a step stool to retrieve this item and come down safely. Whereas when a physical therapist is evaluating them, they can tell immediately that this person doesn't have the proper balance to do so, and this is a bit risky and can easily result in a fall. So we train our patients to avoid these risky behaviors, to ask for help, and to even move commonly used items, whatever they feel like they would need, to a lower shelf, something that's easy to access. We review home safety. There can be a lot of barriers in the home, a lot of potential fall hazards in the home. For example, throw rugs. Throw rugs can be very slippery. We advise a lot of people to remove the throw rugs from the house, or you could also add on a non-stick backing or secure it to the floor so it doesn't slide or move around. This is just one example of a hazard in the house. And we go over suggestions, different rooms of the house, how to create the safest environment. And just reviewing tips to prevent falls and how to recover from a fall, as I stated before. Those who are inactive fall more often than those who are moderately active or very active. Fear of falling triggers inactive behaviors. People who are terrified of falling will not get up, not go for that walk because they're very nervous about falling. But fear of falling occurs in 30% of people ages 65 and older, and it's significantly associated with changes in balance and mobility, muscle weakness, and an increased risk in falls. So statistically, if you're fearful of falling, you are more likely to fall because you're avoiding activity. So we just educate on physical exercise and the importance of movement and physical therapy. We don't want people to be afraid of falling. We just want them to be aware of their limitations and just be aware of safety. Caregiver training. Here in Glen Cove Hospital, we have a caregiver training day. And we have the primary caregiver, a patient's spouse, a loved one, whoever is the person that lives with them and takes care of them. We review the patient's assistance level and guarding techniques and how much help they'll need at home, where to properly position their hands for safety when guarding them. You know, we always say never hold on to someone's arm if you're a caregiver, because if they fall to the ground and all you have is their arm, you pull on their arm, they could have a dislocation or an injury. Hands should always be around the waist. You're able to safely guard someone and help them to regain their balance if your hands are on their waist. We review the potential need for home modification if there are environmental barriers present. If somebody has stairs to get into the house, but only one railing and they really could benefit from two, we advise to install another railing. Or if they're unable to negotiate stairs at all, maybe it's time to install a ramp, and we provide the resources they need to make that happen. We review home exercise program. Before any patient leaves our program, we make sure they have a handout of all the exercises we want them to do at home and the frequency, how many days a week. Sometimes we tell them to do these exercises twice a day. And we also select DME, durable medical equipment. I've had many patients in my experience come to us with the wrong type of assistive device. You know, I've seen many patients come with a cane and their balance is not adequate to walk with a cane. And they wonder why they're falling so much. So we make the recommendation of a safer device that will improve their walking and reduce their risk for falls. And of course, we address any possible concerns or questions that the patient or the family member may have. We want that caregiver and we want that patient to feel confident in going home and feel better than ever and safe and prepared. So durable medical equipment. I have a list of types of ambulatory assistive devices. We have rolling walkers, which everybody is pretty familiar with. It's the walkers with the 2 wheels in front, the 2 pegs in the back. Rollator walkers, which are the walkers. I have a picture in the next slide. It's 4 wheels together, and there are handles to activate the brakes. There is a seat. Canes, you could have a single axis cane, which is just 1 point, or a quad cane, which is 4 points. And quad canes, they come in 2 different types. They could either be wide based, where the 4 points are separated far apart, or narrow based, where they're closer together. There's more stability with the wide base quad cane. Crutches, I typically never prescribe these for someone with Parkinson's disease, but it's just another type of ambulatory assistive device. A hemi-cane, which is a triangular shaped cane, very wide, I reserve for patients following a stroke that have limited use of one side of their body. And the U-step device, which I'm going to talk about in the next slide. So the U-step, the picture on the left-hand side is the U-step. The picture on the right is a rollator. And I just want to go over the differences between the two. So the U-step, it's beneficial for patients with various neurological conditions, such as Parkinson's disease, MS, stroke, ALS, brain injuries, or balance disorders. It has a U-shaped base at the bottom, provides stability and braces in every direction from falling. Very maneuverable, allows for turns in tight indoor areas. If you compare it to a standard rolling walker, the wheels do not turn the direction you want to turn, and you're almost getting resistance as you're turning it. The U-step, it glides very easily as you're turning. It offers a reversed braking system. And what I mean by that is, if you notice in the picture, there's the black handles, but directly underneath them, there's metal handles. And reverse braking in the U-step means in order to make this device move, you have to squeeze the metal handles, and that releases the brakes. So why is this beneficial? Well, for someone who is retropulsing and falling backwards into their chair as they're standing, they're actually able to use the black handles to pull themselves up to stand. As long as those metal handles are not squeezed, those wheels are locked into place and will not move. It's also very useful for someone who is festinating, who's taking those short and quickened strides and is unable to prevent that, is unable to slow it down. All they have to do is let go of the metal handles and only hold on to the black handles, and the device will stop. Whereas something like a rollator is just going to keep moving forward as they're moving quickly forward. And it's very easy to fall with a rollator. There is rolling resistance control in the wheels. If you look at the gray wheels on the bottom, there is a tab. You have to screw it to adjust the resistance. And basically you could set the resistance high so the device will move slowly. If you tend to walk very slowly and struggle to keep up with your device, then there will be resistance, meaning it'll move nice and slow for you. If you prefer to have no resistance on, you could also remove the resistance and it'll go at the speed it's intended to. It does fold. It is foldable. It has a padded seat. If you have endurance issues and need to take seated rest breaks during your walks, you have the option to do so. It also has a storage basket under the seat. You could store your keys, your wallets, your phone. That way you could go for a nice long walk around the block or even to the park. It has a very interesting add-on feature. It's the laser feature, which I'll talk about more in the next slide. It draws a red horizontal line from the gray wheel to the other gray wheel. And basically this line is useful for you to look down at, and it allows you to have a target for each of your steps. So you emphasize the nice long step lengths. So your step lengths are increased. It also has a metronome cueing module that you're allowed to set the beats per minute. And it's just clicks. You'll hear as you're walking. It allows you to maintain a proper cadence and a nice fluid gait. That way you're not stopping, it's not as choppy, it just gives you the cues to follow. One of the biggest complaints about the U-step is it's heavy. It's 21 pounds. And for our caregivers that are a bit older, that need to lift it, fold it, and store it in the car, they struggle with this amount of weight. I've had patients, caregivers say that they love the device, but they prefer to just keep it within the house so they don't have to worry about lifting it and folding it, which is useful too. So in comparison to the rollator on the right-hand side, rollator is very lightweight. It has the 4 wheels, which glide very easily. You cannot set any resistance into those wheels, so it will move fast. You have to squeeze the handles to activate the brakes, as opposed to the U-step where you have to let go of those metal handles to activate the brakes. You have to squeeze for the rollator. It also has a padded seat and a storage basket. So the biggest con is it moves fast. It can easily roll out underneath you if you lean on it. You need to have quick reflexes to use the brakes, and you cannot hold onto the device while you're trying to stand up from a chair. It's going to roll away from you and you may fall. So, of course, my opinion, I think that any new durable medical equipment should be prescribed by a doctor or a physical therapist, someone who can assess and analyze your gait and see what device is best for you. I've had many patients tell me that they've seen their friends using a rollator or a cane, and they went to the store and picked one up themselves because they felt like their friend walked good with it. I probably will walk just as good with it. But that's not the way to go about it. It should always be prescribed by a medical professional, specifically a physical therapist. So auditory and visual cues, very beneficial in Parkinson's disease. Rhythmic auditory cueing, it provides a uniform or pattern recurrence of a beat or accent to offer an external cue to influence motor execution. So we utilize the metronome. If I'm not using a U-step where I have the metronome right there on the device, I have an app on my phone where I could pull up a metronome and just provide those beats. And I tell my patient, walk to the beat. I've also had patients select their favorite type of music, and I'll play it on my phone and we'll walk to the music and try to keep on tempo. So music is actually shown to promote neuroplasticity. And what is neuroplasticity? Neuroplasticity is the brain's ability to reorganize itself by forming new neural connections throughout life. Neuroplasticity allows the neurons in the brain to compensate for injury and disease and to adjust their activities in response to new situations or to changes in their environment. Growing evidence is that exercise can change your brain's environment. So whenever I have people who doubt what physical therapy can accomplish for them, what it can achieve, neuroplasticity is the research behind it. It can change your brain and help to adjust for your injury and be able to adjust your activities and help improve your quality of life. And walking can be aligned with rhythmic auditory cueing to improve step speed, step length, and step symmetry. It may help with start hesitation, freezing, gait stability, walking speed, stride length, and step coordination. For people who freeze a lot, a slower sound cue may help with the festination and the freezing and allow for more time to target longer stride lengths. So visual cues are also very important to improve step length and symmetry of steps. Visual cues can be utilized through a laser pointer, markers on the floor. Sometimes I put pieces of tape on the floor, spaced apart, and have my patients reach for each step to the piece of tape. Sometimes I even attach a little TheraBand to their assistive device, and I have them try to kick towards that TheraBand. Even not having something specific for them to see, but tell my patients, visualize that you're kicking a football every step you take. You know, these are more internal cues, but are very helpful. So we have in Glen Cove Hospital, in our gym, this is a Biodex music assisted treadmill. And it's a treadmill, but it also is linked to a Spotify app where my patients can select whatever type of music they enjoy listening to, and we play it. And it provides visual feedback for their step length. It'll tell them if your step is too short, reach longer on the right leg. It'll give them that feedback. And it also provides results from their performance. And you could save those results and track your progress. In our gym, we also have a harness system. It's connected to an overhead tracking system in the ceiling. So even if I have somebody whose balance is not that great and it wouldn't be very safe to just put them on the treadmill without support, I could put a harness on them and walk at a slower speed. And they have the ability to also get the benefit from this device. The biofeedback from the machine, biofeedback is defined as a training technique that enables an individual to gain some element of voluntary control over muscular functions using a device that produces auditory or visual stimuli. So it does encourage patients' progress. In physical therapy, goal setting is very important. We emphasize patient-centered functional goals. Many of you may have heard the term functional goals, but what does that really mean? And functional goals refers to the individually meaningful activities that a person cannot perform as a result of an injury, illness, or congenital or acquired condition, but want to be able to accomplish as a result of physical therapy. Goal setting should always be realistic and attainable, and new goals should be set after each goal has been achieved. In our program, we meet together collaboratively, doctors, social work, nursing, physical therapy, occupational therapy, and speech therapy. We meet a few times a week to discuss our patients, to discuss their progress, and to just reiterate whatever goals we set for them, an update on their goals. If their goals have changed, if they already reached a goal, we set a new one for them. And from that point on, we could determine their discharge plan and how much longer they need to stay with us in rehab. So I have some pretty great examples of functional goals that I've had from patients in my Parkinson'S program. I've had a patient who was from the Jersey Shore, and a big goal of his was to be able to climb up 2 flights of stairs, which was necessary for him to enter his favorite restaurant, which was situated right on the Jersey Shore. And that was what we worked on a lot until he was able to achieve his goal, and he did. At the end of his day, he was able to climb the 2 flights of stairs. I had another patient who his hobby was sailing. He has a sailboat, and his goal was to increase his dynamic standing balance to be able to safely sail on his boat around New York Harbor and Long Island Sound. And we did a whole lot of balance training. You know, I put him on a lot of different uneven surfaces, a fitter board, which is a rocker board that rocks side to side to simulate being on the sea, throwing bean bags, throwing different objects to simulate throwing the rope that he needs to throw to anchor the boat. So by the end of his stay, his balance was great, and he felt confident in going back to sailing on his boat. So this is a list of questions that I think every person should ask themselves when they're setting goals for themselves. And I'll just read them off. If you were to focus your energies on one thing for yourself, what would it be? What activities do you need help to perform that you would rather do by yourself? What are your concerns about returning to work, home, or leisure activities? How can I, the physical therapist, help you to be more independent? And in regards to long-term, imagine it 6 months down the road. What would you like to be different about your current situation? So Simply saying, I want to be able to run a 5K is not a realistic goal. You want to make it functional for yourself and think about what would be the most meaningful thing in your life for you. So in regards to our inpatient Parkinson's program at Glen Cove Hospital, we utilize outcome measures. And these are special tests that give us indication on where you stand in regards to your balance, in regards to your ambulation. We assess these things. So one of our assessments is the timed up and go test. And we have an iPad. We videotape each patient on initial evaluation performing the test. We videotape them again at discharge. And the timed up and go test is a simple test used to assess a person's mobility that requires both static and dynamic balance. It uses the time that it takes a person to rise from a chair, walk 3 meters or 10 feet, turn around, walk back to the chair, and sit down. During the test, the person is expected to wear their regular footwear and use any mobility aids that they would normally require. A normal score is 10 seconds or less to complete. A score of greater than 14 seconds indicates risk for falls. And from my experience, I noticed what takes people the longest is negotiating the turns during the test. And I think also knowing that they're being timed puts an added level of stress on them. But in my observations, most people do way better on discharge and they have a new level of confidence after their 2-week stay with us. The 5-time sit to stand test, it's actually performed by the occupational therapist. It assesses an individual's ability to transition between sitting and standing 5 times in a row. And a score of greater than 16 seconds indicates a risk for falls. The Parkinson's Disease Questionnaire, or PDQ 39, is a self-report questionnaire. It assesses Parkinson's disease specific health-related quality over the last month. So it's a subjective questionnaire. We like to see how patients feel like they're doing in their everyday lives. Areas of assessment include ADLs, attention, working memory, cognition, communication, depression, functional mobility, quality of life, social relationships, and social support. So we have a lot of different group exercise classes available out there for people with Parkinson's disease now. And I don't think this should take over the role of physical therapy, but it's a great supplement to do in conjunction with physical therapy. If you're only seeing an outpatient physical therapist maybe twice a week, taking one of these courses will be an excellent way to still get your exercise in throughout the week. Rocksteady Boxing is very popular right now. Exercises are largely adapted from boxing drills. Boxers condition for optimal agility, speed, muscular endurance, accuracy, hand-eye coordination, footwork, and overall strength to defend against and overcome opponents. At Rocksteady Boxing, Parkinson's disease is the opponent. Tai Chi is a Chinese martial art that involves a series of fluid motions, generally accompanied by deep meditative breathing. It's slow-moving and low impact, and it's useful particularly in people who may not be able to engage in more intense physical activity. Yoga is an excellent form of exercise for people with Parkinson's. It involves stretching exercises for the whole body. It increases flexibility, posture, and loosens tight and painful muscles, and also builds confidence. Pwr Moves, or Pwr Moves. PWR stands for Parkinson's Wellness Recovery. I just learned about this recently. It's a class that is performed with large amplitude, high effort, and attention to action in multiple postures. These postures can be assumed on the floor, in all fours, sitting, and in standing. They specifically target 4 skills shown by research to interfere with mobility in people with Parkinson's. And this would be anti-gravity extension, weight shifting, axial mobility, and transitional movements. There are other things that people can do. Swimming, you could take a class for swimming or just go, to a swimming pool in the community. Dance for Parkinson's has been very popular. Pilates classes, and other forms of martial arts, all great classes to take. So LSVT big, what is it? LSVT stands for Lee Silverman Voice Treatment. There's another area of LSVT training called LSVT Loud, which deals specifically more with speech and increasing the volume of your speaking voice. Whereas this emphasis is on increasing amplitude of movement. Every movement is on thinking big. It's a one-on-one treatment with an LSVT certified clinician. It's a 1-hour session, 4 sessions per week for 4 weeks in a row. So if you're in the LSVT big program, I think for the 4 weeks, it kind of takes over any other forms of exercise you're doing because it is very intense. There is daily homework and carryover exercise on completion of the program. So you can do the moves every day. Research shows that LSVT big treatment can lead to faster walking with bigger steps and arm swings, better balance, and more ability to twist at the waist. Clinicians also report that LSVT big often helps people with buttoning their clothes, writing, and other small movements, as well as large movements like dressing, getting up from a seat, and getting into bed. This is something that I think I want to get certified in one day, hopefully soon, because I see a big difference when people do take these classes. So some complications, and what I mean by complications is the person's ability to participate in physical therapy can be negatively impacted by certain things. If somebody has a comorbidity, a pre-existing health condition that affects their endurance, such as a cardiac or pulmonary condition, reduced endurance could definitely impact their ability to participate in physical therapy. And we may just have to monitor blood pressure, heart rate, and oxygen throughout our sessions. Orthostatic hypotension. Some of you may be familiar with that term. It's defined as a decrease in systolic blood pressure, or the top number of your blood pressure reading, of 20 millimeters of mercury, or a decrease in diastolic blood pressure, the bottom number, of 10 millimeters of mercury within 3 minutes of standing when compared with blood pressure from sitting or supine position. So basically what happens if you're laying down and you go to sit up, there will be a big drop in your blood pressure and you'll suddenly feel very dizzy. And it can be very unsafe. I've had many patients with this before, and their blood pressure can drop sometimes into the 80s, which would make it very unsafe to walk with them. So we'd have to defer any sort of standing or walking, or definitely no stairs if their blood pressure is this low, because we run the risk of them fainting. It's scary when patients do not feel the dizziness, but their blood pressure still drops because they're adamant about participating in their therapy, but they don't realize it's not safe right now. The blood pressure needs to be managed. And that's usually when we'll escalate it to the doctor and the nurse, that they could get on some medication to help manage and stabilize their blood pressure so it's safe. Off periods, specifically unpredictable off periods. These are the return of Parkinson's symptoms that result from low levels of dopamine between doses of treatment. So you may have received your Sinemet dose, but then all of a sudden your symptoms come back unexpectedly. And we always want to optimize our physical therapy sessions. We want them to feel the best that they can and be able to do the most that they can do. And if a person's feeling off, it's just not going to be the most productive session. High pain levels, of course, can impact physical therapy. It can be due to chronic back pain, arthritis, or a musculoskeletal injury from a previous fall. Of course, we get the nurse and doctors involved if the pain levels are unbearable, and get them Tylenol or any other pain medication they're able to get. And I'll review the benefits of exercise. Of course, we have reduced motor symptoms, improvement in bradykinesia, and postural instability. Exercise enhances the efficacy of levodopa therapy, improves heart and lung capacity, improves endurance, gait disturbances, cognitive function, quality of life, and sense of well-being. And in regards to quality of life, exercise wards off depression, improves sleep quality, blood pressure, attention and brain function, circulation, endurance, strength, mood, energy levels, decreases stress. The list goes on and on about the benefits. Exercise improves efficiency by modifying the areas of the brain where dopamine signals are received, the substantia nigra and the basal ganglia. And physical activity is also shown to stimulate the release of neurotransmitters, dopamine, norepinephrine, serotonin, and endorphins. So you actually get a little rush of dopamine when you exercise. So I will now open it up to any questions you all may have.
Anybody have any questions that they want to ask? You can either put it in the chat or you're certainly welcome to unmute and call out. We don't have that many. Any questions? Maybe we should put it back into gallery. You want to maybe, do you still have slides, Angela?
I just have my resource slide.
Okay, so why don't we just show that? You know what you can do is send that to me and I can send it out.
Sure.
Okay, so why don't you unshare your screen? We can go back into gallery view and then people can certainly raise their hands or whatever.
Okay.
Okay, hi everybody. It's sometimes easier to ask questions this way. You can all see Angela directly. Anybody have any questions? Angela gave us so much information. Much of this was it was so interesting and really helpful. And I know I took some notes for myself. I thought that when she mentioned about the goal setting, I thought that was so important. And I think particularly when you're in a pandemic and sometimes your routine is interrupted, setting goals and setting new goals, even for your Parkinson's, is probably the best way to get through a difficult time like this, especially as winter comes in. So this is certainly the time to be setting all sorts of small, manageable, achievable goals with potential outcomes. So that was one of my takeaways that I thought that's something I'm certainly going to keep in mind as I instruct my clients and myself. So guys, any questions?
I've never heard of the dance for Parkinson's before you mentioned it. And pre-Parkinson's, since I was a teenager, I danced for like 20 years. Just for fun. And I haven't been able to do it anymore. So I was really excited to hear about that. So I'm going to look it up.
Yes, I actually, I provided a website for Dance for Parkinson's.
Yeah, I saw it.
It's danceforparkinsons.org. It's a Brooklyn-based company, and they incorporate different styles of dance. It could be ballroom, sometimes tap dancing, all different kinds, and they modify it for every patient. They keep the classes small, so they have staff members there to help in case somebody is unsteady or unable to balance on their own. And they could modify it if you need to sit down in a chair to do the dance moves. But yeah, we're trying to get some dance sessions here at Glen Cove Hospital, which I'm very excited for. Obviously it will have to wait until after COVID dies down a bit, but yeah, definitely check out that link.
I will. Thank you.
You're welcome.
Anybody else? Anything you want to ask Angela? This is your chance. Questions, and even something about yourself, if there's something you've been trying to figure out or have questions about your own therapy, because this, it's a small enough group, you can certainly ask a question. Wow, okay.
Well, I'd never heard of the U-Step either, but I took away stuff from your slides and your talk that I'm going to work on with my mother. She doesn't have Parkinson's, but she's going to be 82. So I finally got her to get a rollator. I finally got her to go to physical therapy, and I'm going to use some of the stuff that I've learned and you just spoke about to get her healthier.
Yeah, absolutely. There is a link as well to the U-Step. It does require a prescription and a letter of medical necessity. Medicare reimburses up to $400. It's an expensive device, but Medicare reimburses almost the full cost of it. And if the add-on feature, that laser and metronome feature, was something you're interested in, that's an add-on feature. It's not covered by insurance, and it can run up to $269. It's expensive, but it's a very helpful device.
Yeah, I don't think she needs it. It took me long enough for her to get her to use get a rollator, but she was walking around using a cane, and I thought she was gonna fall like every day.
Like
Yeah.
the worst
So-
decision. It's like the worst decision people make. Is
I
that
Very, she's not aware of her physical conditions and limitations, and
right.
hey, she's old. She's been doing it, you know, her own way her whole life.
It's true. It's true. We just want to keep people safe. I think, you know, we talk a lot about enhancing and increasing stamina, but really the most serious part of this is you want to remain safe and want to make sure that you don't fall, because as we all know, falls change everything in terms of your life. So I'm glad that you had that emphasis on fall prevention, because that is so important. Anybody else have a question?
Yes, Angela, thank you very much for a very interesting hour. I enjoyed it very much. Let me ask you a question.
Sure.
What about itching? Is a side effect because of the medication they take? It causes you itching, or your body itches, or is that just a side effect of some other disease?
It could be. It depends on the medication you take. I have heard from different patients, certain medications does cause itching. Yeah, I actually had a home care patient that once he started taking, I don't know if it was his Cinemet or it was like
Cinemet. Yeah, I use Cinemet.
it may have been his anti-seizure medication that he was taking that was causing a lot of itching. But he actually went to his doctor, he brought it up, and he was prescribed a topical cream that was able to manage that. So he was still able to take his medications, but manage the itching with like a topical steroid cream. And that helped.
Thank you.
You're welcome.
Anybody else?
Angela, I have a question for you.
Sure.
Do you have a like a generic kind of daily exercise routine that you recommend that I can find somewhere?
So I don't like to give generic routines. I like to tailor fit the exercises I prescribe to each of my patients just based on whatever their needs are. If there is, something in their walking that indicates muscle weakness in certain muscle groups, then I target those muscle groups and prescribe exercise. It's very easy to give just a generalized program, but it's not very cookie cutter. I like to tailor fit them to each of my patients. But you can definitely, go on Google, look up exercises to strengthen your legs. There are tons you could do in sitting and in standing, but, I would recommend either seeing a physical therapist or, I wouldn't necessarily just look for a general program because it may not be the right exercises for you.
We do have, I have to say, although I do agree with Angela, if you go on the JCC website, I think on the social services page, there is our director of wellness at the beginning of the pandemic did an exercise routine for people with Parkinson's. So there is one. And we also have our YouTube channel does have a series of about 25 to 30 minute exercise routines that are all different. So some of it would be more appropriate than others, but I think, I think the caveat, and I think Angela agrees, you have to be careful. It's like, we don't want to encourage you to do something and then you find out you end up hurting yourself, which I'm assuming you can if you're targeting the wrong areas, the wrong muscles, but there are some generic exercise routines on our website. So you're certainly welcome to check it out.
Are any of them chair oriented?
Yes. Yes, they are. And everything she does, you can modify. Yeah.
Good,
But
thank
it's all
you.
on our website.
Angela, do you think with the fascinating gait, it's strengthening the leg muscles is a key thing that you need to do?
Yes, strengthening leg muscles, specifically getting your hip flexors stronger so you're able to take a higher step that your feet leave the floor, that you're not kind of glued to the ground when you're walking. You know, trying to target to land on your heel with every step you take. You know, we discussed the internal cueing you could provide yourself, those rhythmic auditory cueing. Sometimes people just sing a song in their head or count. You know, as you're walking, that kind of helps for you to maintain your normal rhythm, your normal cadence. And basically don't force the movement to happen. If you're in a stressful situation where, you know, you're frozen, you're trying to get out of the freeze, maybe you're trying to enter an elevator and, you know, there are people waiting on you and you start festinating real bad. I just recommend stopping, planting your heels down. Don't force through the movement because that could result in a fall. You could do a little like marching in place or just go 1, 2, go, and big step and walk inside.
And that's a perfect example of when the festinating happens to me, when I'm getting ready to go in or out of an elevator.
Yeah, it's very common because, again, stress kind of exacerbates your symptoms. So you kind of just have to pretend nobody's in there. Just focus on another muscle movement and just take a big step forward.
Angela, in regards to Victor and freezing, in our boxing class that we're in together, I've at times told him to step back 1 step and then step forward, restart the motor.
Yes, that's actually a really helpful one. You could do any sort of movement that separates you from that forward festinating that you catch yourself up in. You know, you could do a side step even, or you could relax the legs completely, lift your arms up towards the ceiling, back down, and then go. It's just you need to provide your body with a reset. That way you're not stuck in that movement where you're going to continue and potentially fall. So yeah, activating different muscles, doing backward stepping, side stepping, just something different than the forward festinating pattern.
What's the word festinating?
Yeah,
You
it's
keep saying that. What does that mean?
So it's when you're frozen and you're trying to break out of the freeze and you start shuffling at an increased speed up onto your toes. It almost looks like you're falling forward onto your toes.
Exactly.
Very quickly. So this results in falls a lot of times.
Yeah.
It's referred to as festinating.
The word sounds like what you're doing. You know how some words sound like what you're doing?
Yes.
Festinating actually sounds like yeah.
Like
exactly.
stuttering of speech, festinating of gait.
Right, festinating the gait sounds like you're doing it. You know,
Like
you're rushing forward.
It's like a super fast shuffle step where
Yep.
each step is maybe like not even a half an inch long.
Mhm.
Yeah.
And you're if you have that forward leaning posture like I do sometimes,
Mhm.
right, your body goes forward and your feet are behind, so that's a fall.
Yeah,
But
yeah.
I thank God I haven't fallen yet.
It's just a great word that describes it so well. Yeah.
Angela, diversifying exercise routine weekly, keeping it real, keeping it mixed up. Do you feel, how strong do you feel about that?
I feel it's very important. You know, just with goal setting, once you achieve a goal, you need to upgrade your goal to reach the next best level. If you stick with the same exercise routine, even though you're strong and you're able to do it easily, you're not challenging your body. You're not going to be able to see the benefit. So I definitely think the progression of exercise is crucial to gaining strength. Definitely.
Angela, do you think step training is good for strengthening the legs?
Like climbing up and down stairs?
Yeah.
Absolutely. You know, I think it's a skill everybody should have, regardless if you have stairs in your home or not. It definitely requires a lot of muscles activated to be able to accomplish the task. And not only that, even if you don't have stairs in your house, there are stairs everywhere. There could be stairs in your doctor's office. There could be stairs in a restaurant, just like the patient I had. You know, it's a skill you don't want to lose. And I would strongly encourage people to try to practice it as much as possible. It's a
What
good
if you have
strength
bad knees?
Hmm?
What if you have bad knees?
If you have bad knees.
Well, usually we need to strengthen the muscles surrounding the knees. You know, if they're bad, that means that there's a decreased stability in the muscles and muscle weakness. By strengthening all those muscles surrounding the knees, you're giving yourself a support, almost like a brace around your knee. So it may be painful in the beginning, but as you gain strength, it'll get easier.
Thank you so much.
You're welcome.
Angela, do you have a suggestion on how to like go up and down stairs? I use a rollator. So even if I grab on something to help myself go up or down the stairs, my rollator's stuck where I started.
Right. You know, if you have a second person with you that's able to bring it up the stairs to the landing where you need to be, that'd be the most helpful thing, because it could get unsafe trying to carry a rollator while you're trying to step
Yeah, I
up.
can't do that.
You know, a lot of my patients at home, they'll have one device on the second floor and another device on the first floor. That
I
way,
moved to a 1-story so I didn't have to walk up and down the steps, because also the steps were very narrow.
that could be hard.
So yeah, I was scared to go up and down them. And even on the on the second floor, the landing was very narrow. So it was fun when I was a kid, but not when you have Parkinson's.
Right, of course. No, so, you know, you luckily don't have to worry about getting different devices on the different floors, but even when you're out, it can be cumbersome, like transporting that rollator up to the second level, wherever you need to go. So, yeah, if you have somebody with you that could just assist you by bringing that rollator up for you so you could focus on safely climbing the stairs, that's my best recommendation.
Thank you.
You're welcome.
Okay, I think we're good. All right, everyone. Thank you so much. Thank you, Angela, for that really informative, interesting discussion. Just remember, there is an inpatient unit at Glen Cove Hospital. I don't think at this point that they are taking new clients, but certainly as soon as this crazy pandemic that we're in ends, hopefully they'll restart. Angela's going to send me the resources. I will send them out to everyone so you have them. And just remember, we have another Northwell presentation in December 17th, I think, on occupational therapy and Parkinson's. So that should be really interesting as well. All right, everybody, I want to wish you all be safe, take care of yourselves, and hopefully we'll see each other soon. All right, everyone.
Thank you very much. Thank you, Angela.
Hi, thank you all.
Thank
for
you, Angela.
attending.
Take care.
Thank you for,
Pleasure.
You're
Bye-bye.
welcome. Take care,
Thank you so much.
everybody.